Let's jump right into this explainer, breaking down a massive new meta-analysis on late-window tenecteplase for acute ischemic stroke. For years, that 4.5-hour mark has been our hard and fast boundary, right? Well, today, we're unpacking the data to see exactly what happens when we push TNK all the way out to 24 hours. We're tackling the exact clinical dilemma you're likely facing right now. Is pushing IV TNK beyond 4.5 hours actually worth the risk, or is any potential benefit just completely overshadowed by endovascular thrombectomy? It's a huge question. While EVT is obviously the gold standard for large vessel occlusions, we have to acknowledge a pretty stark reality. Global access to EVT is shockingly low. We're talking under 3%. So we desperately need to know if TNK can hold its own in the late window and, conversely, how it performs when EVT is sitting right there, ready to go. Okay, here's your methodology quick hit. We're looking at 1,278 patients across 4 major RCTs: ROSE TNK, Timeless, TRACE-3, and CHABLIS-T. All of them used perfusion imaging to select patients in that expanded 4.5 to 24-hour window using a 0.25 milligram per kilogram dose of TNK. But here is the critical variable you absolutely need to pay attention to. 2 of these trials strictly prohibited EVT, while the other 2 permitted it. And as you'll see, that distinction literally changes everything. Looking at the overall pooled efficacy, the short answer is TNK delivers. In the late window, patients getting TNK had an odds ratio of 1.34 for hitting excellent functional outcomes, so an MRS of 0 to 1 at 90 days compared to standard care. Plus, the recanalization odds ratio was a highly robust 3.3. The bottom line up front, late window TNK absolutely works. But let's pause for a second, because we have to address the obvious safety anxieties. Pushing lytics out to 24 hours naturally sets off alarm bells about hemorrhagic transformation, right? Well, the data here is incredibly reassuring. The odds ratio for symptomatic intracerebral hemorrhage was 1.68, but with a completely non-significant p-value of 0.17, meaning extending that thrombolytic window did not significantly bump up bleeding risks or 90-day mortality. The safety profile actually holds up beautifully. Now, to truly grasp TNK's real-world utility, we have to split this data right down the middle into 2 distinct clinical realities: centers where EVT is strictly prohibited versus those where it's permitted. Historically, pooling all these patients together kind of masked the true isolated effect of the lytic. So let's look at them separately. And here's the absolute crux of the findings. In the non-EVT subgroup, TNK bumped the odds of excellent functional outcomes by a massive 46%. But, and this is a big but, if the patient was in an EVT-permitted trial, that functional benefit effectively vanished from the statistics. Think about what that means. If a patient has absolutely no access to a cath lab, TNK is a total game changer. But if they're heading straight to thrombectomy anyway, the functional boost from the TNK is statistically muted. The recanalization data perfectly explains why this is happening. The non-EVT group shows this wild odds ratio of 6.17 for recanalization with TNK. It is highly effective at busting that clot all on its own. Now, even when EVT is permitted, TNK still improves initial recanalization. You're looking at an odds ratio of 2.36 there. So the drug definitely opens vessels in both scenarios. But here's your EVT-permitted reality check. While TNK definitely improves that initial recanalization, the sheer, immense effectiveness of the subsequent thrombectomy essentially dilutes any observable long-term functional benefit from the TNK itself. Mechanical thrombectomy is just so incredibly successful at achieving reperfusion, we're talking around 75% of the time, that it basically eclipses the clinical boost provided by the pre-procedure TNK. The lytic does its job and opens the vessel, sure, but because EVT is so definitive, the long-term 90-day functional scores end up balancing out entirely between the 2 groups. So how do we actually translate this data into your day-to-day practice? Well, the data proves TNK is an absolute lifeline, an essential standalone reperfusion strategy for resource-limited settings without EVT access. If you're at a primary stroke center or a rural hospital where transferring for thrombectomy might take hours or just isn't happening, late-window TNK is a highly effective, demonstrably safe intervention. However, for comprehensive stroke centers with an active, ready-to-go cath lab, TNK serves a much more nuanced bridging role. Yes, it improves early recanalization, but you just shouldn't expect it to independently shift your 90-day functional outcome metrics if EVT is going to be performed promptly. I want to leave you with a final, provocative thought to take back to your clinical teams. Based on this very stark EVT divide we just looked at, how will these findings alter your institution's drip and ship or direct to mothership protocols starting today?
Are you ready to confidently utilize TNK all the way up to 24 hours in your non-EVT patients? Because this is a genuine paradigm shift for resource-limited settings, and one that could seriously reduce the global disability burden of ischemic stroke.